we have a QI meeting every couple months going over our mortalities and morbidities. So I had the person that runs it send me the list of patients that died in the last 3 years to sort of better understand, to look at what happened. And I'm just going to highlight a few points. I'm not going to go through the specific cases, but wanted to highlight a few points. And I think we have a much better understanding of the patients, the procedure, and everything else. And it's really, the procedural mortalities are less now than they were in the past, but they still occur. And there are some issues that we still have to be cautious about. Sorry. They're not advancing. Oh, now it goes. Okay, great, thank you. So when we look at the 30-day mortality post-TAVR, as we've gone through the different trials, and I just sort of focused on the trials, the mortalities have clearly gone down as we got to a lower risk population. Now, what's challenging with this data is during the 10 years in which these trials were done, there's been a ton of device iteration, there's been a lot of procedural learning. So the mortalities are lower because we're better at the procedure, but then potentially also because we're treating a lower risk population that can handle complications. And there's a lot of reasons for improvement. Devices have iterated, there's been increased operator experience with fewer complications, there's been refinement in procedure technique, and in general, we're treating a lower risk population. I'm going to go through some of these, but the causes of in-hospital mortality, there's obviously the acute procedural catastrophe, and we've all had these, an LV perforation, an annual rupture, aortic dissection, coronary occlusion. I think we're better at predicting them, and also even if we don't predict it, we're better at handling them if they occur. And I think they ideally don't result in a procedural mortality, but in some of these patients, if you have one of these events, it's the course sequence of events that it creates that leads to their death. But you have to be prepared to handle these complications. But as I said, despite a successful rescue, it may still lead to poor outcome depending on the patient protoplasm. And it's just an example. It's a 93-year-old woman, elderly, high risk, but functional. She was inoperable for her age, but also had a very porcelain-looking aorta. You can see the heavy calcium. We didn't get a CT. This was more than 3 years ago. This was about 5 years ago before we were doing CTAs on all of our patients, and her creatinine was a little bit up as well. But we did 3D angular sizing. Area was 478. We put a 26 millimeter sapien valve, and you can see what happened afterwards. You see this extravasation of contrast here. It was an annular/root rupture, immediately hypotensive. You see a large pericardial effusion. We put a drain, we auto-transfused, and as we were doing that, she was not surgical. We put a second valve. The idea was you put a second valve just to sort of touch the first, and the leaflets of the first will help seal the perforation theoretically. And remarkably, it worked. The drainage stopped, so we didn't open. She actually got extubated a couple days later. She got discharged, but it's the series of events. She survived 30 days, she went to rehab, but she died around 3 months from a pneumonia and sort of complications, right? But she was home, she recovered from this procedure, but I have to still think that at some point is the fact that this took a little bit more out of her led to her death. We rescued from the original event, but we didn't get her the result that we needed. We've had now 2 or 3 of these annular ruptures that we've sealed with a second valve, which can work sometimes depending on the anatomy. This is a more recent case, and I don't know what people do. We don't routinely have cardiopulmonary bypass in the room. Our idea is there's a pump somewhere nearby in the hospital. We have cannulas in the room, so by the time we cannulate, the perfusionist will come with the pump. This is a patient that was done relatively recently, it was last year. It was a type 1 bicuspid, fusion of the right and non, as you see there. Sinuses were big. We did a 26 millimeter balloon, put a 26 millimeter sapien 3. Sort of unremarkable, fairly straightforward. Position looked good. We're about 2 millimeters below the annulus, and sizing was in good range for a 26 millimeter S3, and sinuses, as I said, were 34. Acutely hypotensive, refractory hypotension, wall motion abnormalities. You look at this aortogram, there's no flow in the left coronary. And so we cannulated, the perfusion got there, we put them on ECMO, and you see on that right side, that white line, that's the leaflet. We had essentially sealed the entire sinus of the left coronary sinus. We were able to get a wire around it, do a PCI, and the patient was a lower risk patient. right? It was an intermediate risk, but a more functional than that 94-year-old, still got weaned off ECMO in the room, went home on day 4. So one tolerated the complication, one did not. It was part of the protoplasm. We rescued both, but one made it, one did not. But if you look back at this, there was a 26S3, but there's the fusion of the right-left. And what it did was it didn't allow the valve to expand in that direction, so the entire SAPIEN 3 was sort of pushed toward the left main. And you can sort of see that here. And so the valve is sitting more canted toward the left main. And when you look at here, what you see here is the sinus of the left sinus is shorter. So we essentially sealed the sinus. We could have anticipated it, but we probably still would have done the case because you can't really completely model it. We probably would have had perfusion in the room rather than not. But those are the type of things you have to be able to handle, because even with the most experienced, there are going to be unusual cases like this, and you can argue when you look at it, yes, that makes sense. But we've done cases like this where it didn't happen, where the sinuses are big and we have plenty of room, but these are, again, things that we look out for. So again, it's these things that extend hospitalization that lead to mortality. And it depends on the patient protoplasm. You know, we saw early on from the partner trial, if you had a complication with the procedure, whether that major vascular, major bleeding, any of those major stroke, mortality was about 3 times higher. And this was in a high-risk population, early experience, but mortality is increased complication. And when we talk about the complications, we've talked extensively about stroke, and these are typical cases: 82-year-old, functional, STS of 4, has a TAVR, acute procedural result, no hemodynamic issues, went very well. Extubation, dense left hemiparesis. We take these patients, this case was done asleep due to some sizing issues, but we take them urgently to the neuroangio suite. You know, they weren't really able to extract much. It was sort of a diffuse embolic event. There wasn't much to remove. She had really minimal improvement over the first 48 hours. And after about a 4-week course in the hospital, she died from respiratory failure. Deconditioned in bed, got a nosocomial pneumonia, and passed away. So that's why stroke increases mortality, right? And we talked earlier about what can we do to reduce the stroke risk. Stroke more than triples the mortality across multiple studies. The neurologic event rates are decreasing, but they're not zero. Even the TVT registry, they're still around 2 to 3%. They're unpredictable. They don't go away with experience. So again, you're going to have to accept that. It depends on, again, the patient protoplasm. And I'm not going to go through this again because we had an earlier session, but there are potential ways to mitigate the risk of stroke. Nothing's 100%, but we have to think about it. Another thing that often leads to extended hospitalization are vascular complications. Now, this slide on the left is one of our first cases back in 2006. I've seen this slide used by multiple people across multiple presentations and it always gives me PTSD. Because before we did any CT scans, it was an angio and said, okay, it looks okay. That's different than this patient, where this is more recent, but the closure didn't work. It was sort of a high stick, and you see the bleeding is not out, it's going retroperitoneal. Both of those can lead to the same event if you don't treat and manage and recognize appropriately. Now, the one on the left, we had to do an aortic iliac bypass. Patient was in the hospital about 4 weeks. This again a long time ago, and patient survived. Never got the TAVR and never wanted to come back for the TAVR, even when we started doing transapical, which we didn't blame them. But the one on the left, we managed percutaneously with a stent. But if you don't do angiography and recognize that early, that patient can also have a bad event. Large bleed, retroperitoneal, debilitation, goes into renal failure, hypotensive. So if you do an angio and you recognize that and we put a covered stent, that limits the consequences. And so that patient got a stent, did well, didn't get a transfusion, and so it was early identification, early treatment. And so we do a crossover wire in every case for that reason, because this happens maybe 1 out of 100 times, maybe 1 out of 150 times, something this significant. But that was enough for us to sort of prevent it. And so the sheet sizes have made the complications less. And so bleeding and vascular complications. So life-threatening bleeding is one of the biggest predictors of 30-day mortality. There are different analyses. This is just one. But getting transfused, and these are significant bleeds. You generally transfuse more than 3 units, especially over 5 units. It leads to higher mortality. And readmission and bad events. So bleeding and vascular complications lead to these events. Now, majority of those are intraprocedural, and you see that in-hospital mortality, that bump on the blue line is from the procedure-related bleeds, but a lot of these elderly patients also get other bleeds. You anticoagulate, you put these patients in the hospital, they're under stress, they get a GI bleed, then they go endoscopy, then they go stay there for another week, they have other issues. It's those events that always lead to bad events. It's not just the procedural bleeding, but it's the non-access site-related bleeding as well that even more so has an increased hazard for mortality. Renal failure, that's a big problem. So this is from the core valve study, and you see more than 50% of the patients have a GFR less than 50, from 30 to 50. And about 10% of patients have a GFR less than 30, and this is in a trial which excluded severe renal failure, right? So when you have severe renal dysfunction, it leads to higher mortality, both in early and late. And when this is in the partner trial, GFR less than 30 again. You see here, there's a large percentage of patients that have a GFR less than 30. It leads to an increase in 1 month, 3 month, and 1 year mortality. So we try to mitigate the risk of renal failure. We space out contrast requiring procedures. If someone has a creatinine 2.5, they get a cath, we wait 10 to 14 days, do the CTA if we're gonna do it. If we do a CTA, we do a low dose, 20 to 40 cc's. And then we minimize the contrast load. If they have severe renal dysfunction, we just get a non-con CT to look at vasculature. Otherwise, we'll skip the coronary angio and just get a stress test sometimes. We do all of these TAVRs with severe renal dysfunction under GA with TE guidance. So we've done about a half a dozen cases now with no contrast. These were patients with severe allergies to contrast, but you can do a whole case, ultrasound access, and then ultrasound assessment after and TE guidance. And the other key thing is optimizing hemodynamics. These patients have reduced GFR. If they have come in with a wedge of 30 or 40, their likelihood of going to renal failure is higher. You got to diurese them, get them optimized ideally in the hospital, and avoid hypotension during the case. That's what leads to further renal failure. Infection. We've all had these scenarios. This is, I consider, become a deadly weapon, the Foley catheter, right? It leads to a lot of events, especially in men. You have this male with the BPH, the nurse has a hard time placing the Foley, it tries multiple times, and they try a coude, and they end up with hematuria. Then they're long hospitalization, then the catheter doesn't come out, then they get a UTI. Or even if they get the Foley and they can't get the Foley out, it's urinary retention. They get a UTI. And this is just our experience. This is before, we stopped doing routine Foley 3 years ago. And this is before. So in patients with an indwelling catheter, we had urologic complications in about a third of the patients. And when they have a urologic complication, it led to significantly higher 30-day mortality. So I think the Foley is something that we have to keep in down. And you got to avoid Foleys. Even in general anesthesia, we don't do Foleys. If you have you need one, it's someone with a complex anatomy, have urology do it potentially. We pre-treat our patients with Flomax, ideally 3 days, but most often just the day before, but ideally it would be 3 days. Avoid anticholinergic and heavy sedation afterwards to try and mobilize them early so they can stand up and urinate earlier. And those are the things that we can do. But the reality is, it's all these patients, it's the risk profile that impacts outcomes. These elderly patients that are on the right end of that risk spectrum, they have less reserve. They can't tolerate a complication. And they, sort of slipping on that banana peel. Everything's going great, and then something happens, and that's it. And so you don't have reserve in these elderly patients. You got to do everything you can to minimize these events, and they're just more prone to infection. And so, really it's about who does well with TAVR rather than, before the conversation, who doesn't do well with surgery, let's just try TAVR. That's why we got into trouble. But understand who does well with TAVR and who not to treat, and that will improve your outcomes. Severe oxygen-dependent COPD has bad outcomes, and we've seen this in multiple studies. When you look at either 30-day or 1 year, when patients are not mobile and they're on oxygen, the outcomes are poor. 30-day mortalities are as high as 10 to 20% in some studies. So you got to be careful, and those are not patients. And so you get to these really frail bed-bound patients, their mortality is not driven by the procedure, it's driven by their protoplasm. And if you can't optimize them to get them better, then consider not treating them. And we've seen this in the partner cohort B analysis. When you have an STS above 15, as you see on that right, there's no difference between medical therapy and TAVR. So to get an STS above 15, you have a lot of medical comorbidities, right? So in that patient population, you may not get the benefit. In the last minute and a half, I have a couple not mortalities, but sort of interesting cases. So we did there's no reason for us to use a true balloon, but we got it on the shelf, we wanted to try it. So it was a TAVR, we were pre-dilating, so we used the true balloon. After the balloon inflation, you see this thing flopping around in the sinus and the aorta. We weren't sure what it was, whether it was leaflet or endothelium. We decided to go ahead and put a valve in. And at that point, we'd already there, BAV, we put the valve in. Then look what happened to the flap. It went into the left main. That piece of endothelium is now in the left main. So then we were sort of trying to decide what to do. We IVUSed it. You can see the flap on the angio. You can see the flap. We elected to stent it. Now, I don't know if anything would have happened, but you could imagine that if you have a piece of endothelium sticking in the left main, it could lead to thrombosis and an acute coronary. And we only noticed this because we did this with TE. If we had done this awake without TE, we wouldn't have noticed. I don't know that anything would have happened, but it's something to be concerned about as well. we had another patient that had uneventful TAVR, 24 to 48 hours later had abdominal pain, lactate rose, kidney shut down. Patient had an acute abdomen, general surgery was called. The CT was consistent with sort of necrotic bowel. Family elected for palliative care, and the patient died. Why this patient had a gut embolic event, I don't know. This is not the CT. I couldn't find the CT, but it was someone with an endograft and similar type of anatomy. I don't know that we could have done anything different except maybe go at transaortic, but we have plenty of these patients and we don't do it, but this is a patient that died from gut embolization. The only way to avoid it is not to have gone through the abdominal aorta or the arch and done a TA or something. And the last one is sort of humorous, not humorous, I shouldn't say that. 8-year-old woman, successful TAVR, had a right bundle. We're in this pathway now of early mobilization, early discharge. Her EKG the next morning was same, right bundle, AFib, heart rate in the 80s. No immediate issues. Baseline EKG, as I said, was AFib with the right bundle. She was ambulating the next day. We were getting ready for discharge. She got sent down for a discharge echo. Do you guys see the echo? The tech kept getting clips, but the patient was asystolic. So you see there's not much movement there. Anyway, she got resuscitated, came back up and got a pacer. But if she hadn't gotten her echo and got home that day, she probably would have passed away that day. And we need to be a little bit thoughtful about some of these conduction abnormalities and maybe watch them 2-3 days, and make sure, but I don't know what the right answer is. So in the end, what I'll say is careful review, in terms of reducing risk, careful review the CTA to understand high-risk features is important. You identify vascular and aortic anatomy that adds to the risk and try and manage the risk. Patients with renal failure, try and manage their profile, optimize the patients prior to the procedure. If possible, avoid in-hospital urgent cases. These are patients that are more prone to infection, more prone to complications. Optimize them if you can get them out, get them to rehab, come back as an elective procedure. They have more reserve to tolerate a complication. Minimize contrast, avoid unnecessary lines, neck lines, radial art lines. We avoid Foleys in all these patients, early mobilization. Thank you very much.
Thank you very much for an excellent talk. Probably discussion at the end, maybe?
I think it would be better if we keep the discussion at the end because we are already late. We have